Hello, my name is Zhang. I'm field graduate at University of Cambridge in the United Kingdom. The paper I will be presenting today is titled Exploration of the Association between urine, serum uric acid and urine albumin-to-creatinine ratio in adult, NHANES 2011 and 2020. Hyperuricemia, traditionally associated with kidney stones and gout, has now been linked to type 2 diabetes and various heart and cardiovascular conditions. A high SUA level may worsen insulin resistance by influencing lipid and glucose metabolism. Additionally, elevated UA level are associated with renal failure, cardiovascular disease, and hypertension, suggesting a potential role in the development or progression of kidney damage. Well, in urine, level of albumin and creatinine serves as indicator of renal disease, with proteinuria being a risk factor for deteriorating kidney functions, heart disease, and mortality. The urine albumin-to-creatinine ratio, which we called UACR, is a commonly used measure for albuminemia, with specific threshold for normal levels. Recent studies have identified a correlation between SUA and UACR in individuals with type 2 diabetes. We'll understand the relationship between SUA and UACR can provide valuable insights for improving the treatment of hyperuricemia and proteinuria. The NHANES study employed a complex samples method to collect data from diverse US counties. Blood samples for measuring SUA were obtained using a specific instrument and methodology. The urine albumin-to-creatinine ratio was calculated by dividing urine albumin by urine creatinine. Urine albumin measurement was conducted using a fluorescence immunoassay method, while urine creatinine level was used for diagnosing and monitoring kidney disease. The study also incorporated other measurements such as BMI, biochemical indicators, diabetes diagnosis, and CKD status. And here is the data selection procedures. The primary data consists of individuals who took part in every 2-year cycles from 2011 and 2020. To ensure the accuracy of the analysis, certain criteria were used to include participants for the examination. Out of initial 45,000 participants, the cleaning procedure was applied systematically. It first excluded individuals under the age of 18 years old, then those missing albumin-creatinine ratio data, and finally those without SUA data. These exclusions resulted in a final sample size that were used to further analysis. And we use R for statistics analysis to ensure the consistency and accuracy. And we use univariate and multivariate linear regression to find correlations considering age, BMI, diabetes, and CKD histories. Well, in this study, we analyzed data from 25,000 participants encompassing different ratio group. Our finding indicates slightly higher average SUA and UACR values for men in comparison to women. SUA levels were categorized into 4 groups, showcasing a variation across the population. Subsequent analysis examined UACR levels with values above 13. Participants with high UACR level tend to be older and exhibit higher levels of blood glucose, urine albumin, and SUA. On the other hand, they have lower urine creatinine levels. Overall, men tend to display slightly higher values in comparison to women. Well, you can see the following table presents the results of the regression analysis conducted in our study. The R-square values presented the explained variance, while B signified the regression coefficient. Well, in univariate analysis, several variables, including age, BMI, serum glucose levels, serum albumins, and SUA, demonstrate positive association between UACR. A multivariate analysis revealed that increasing age, serum creatinine levels, and serum glucose levels were associated with higher UACR levels. Conversely, serum albumin and SUA were associated with lower UACR levels. The association between SUA and UACR remains significant in certain subgroup. However, this significance was not observed in mild with CKD, individuals aged 65 and older, or those with obesities. When analyzing our cohort, we combine data from multiple NHANES cycles and assess a cohort of over 24,000 adult males. We investigate the relationship between SUA and UACR using both univariate and multivariate linear regression. Interestingly, through a significant correlation between SUA and UACR were found. The nature of their association differs when comparing the two types of analysis. The positive coefficient in the univariate analysis indicating a connection, whereas it turned negative in the multivariate model, suggesting a possible absence of a causal relationship. Well, you can see the screen that one hypothesis put forward suggests that increased SUA level might induce endothelial dysfunctions, altering UA metabolism and subsequently renal damage, resulting in proteinuria and abnormal UACR ratio. Elevated SUA has the potential to cause endothelial dysfunctions, impairing blood flow and promote inflammation. And dysregulated UA metabolism coupled with formation of UA crystals can further compromise the renal cells. We can see hypothesis 2 composed that elevated SUA level activate the NLRP3 inflammation pathway, triggering oxidative stress and inflammation in the kidneys. Activation of this pathway can lead to endothelial dysfunctions and renal cells damage, thereby contributing an abnormal UACR level. Well, in summary, our study elucidated a significant association between SUA and UACR level within the general US population. Nevertheless, further investigation was warranted to fully comprehend the causal relationship between these variables. The employment of a large and representative sample bolstered the reliability of our findings. We employed various statistical methodologies while controlling for confound variables. However, limitation of our studies include its cross-sectional design, limited measurements of certain levels, as well as the absence of investigation into the effect of free and bioactive UACR and SUA. Therefore, additional prospective studies conducted on a larger scales are necessary to comprehensively explore these relationships. And that's all. Thank you for your kind attention, and I'm more than happy to address any questions you may ask.